Our speaker is Monica Bryant. She's a cancer rights attorney and adjunct law professor at the John Marshall Law School in Chicago. She graduated from George Washington Law School and was previously the Midwest Regional Director of the Cancer Legal Resource Center. You have some handouts here in front of you. She will be here with us till the end of our session. If you have any questions, please ask Ms. Monica, and I'd like you to welcome her. Thank you. Thank you. How are you guys all doing? Afternoon, day one? Overload yet? A little bit? Well, so I have good news and bad news. Good news is I will try to make this as entertaining as possible. The bad news is we are going to spend the next hour talking about health insurance. So my name is Monica. I am an attorney. Lots of times at conferences like this, people are very confused as to why there is an attorney listed. The reason is that we believe that having a basic understanding of your rights and benefits is critical to being the best that you can be and to being the best advocate for yourself that you can be. So we're going to talk a little bit about health insurance. How many of you feel like you have a really good grasp on what's included in your health insurance, how to shop for health insurance, and how to use it? Okay, so we've got some hands. That's great. How many of you feel like you have a really good understanding of the Affordable Care Act? Yeah, so hopefully by the end of today, there will be some more hands because we are going to spend a lot of time talking about the Affordable Care Act and some new rights and benefits that you might be entitled to. So for anyone who came in late, there are a couple of handouts that I encourage you to pick up available in the back. So before we get started, I want to make sure that we're all on the same page with respect to a couple of terms. So the first term I want to talk about is your premium. Your premium is what you're going to be paying monthly for your health insurance, whether you access health care or not. So even if you don't go to the doctor for the entire year, you're still going to pay your monthly premium just to have health insurance. The next term is your deductible. And this is so we've had a request to maybe turn the lights down a little bit so that the PowerPoint is easier to see. Is that possible? Looks like someone's working on it. So yeah, absolutely. So your deductible is going to depend on the individual policy that you have, so it's going to differ for each one of you. But it's the amount that you actually have to pay out of pocket before your health insurance policy will start to pick up their share. Which leads us to copayments. Copayments are also going to depend on your policy. Different services will have different copays. And again, that's an amount that you're going to be paying out of pocket when you access health care. So a lot of times somebody has a copayment every time they see the doctor, so maybe you have to pay $25 before they even let you in the door to see your doctor. Sometimes it's with prescription drugs. Every time you pick up a prescription at Target or Walgreens, you have to pay your copay. And then finally, co-insurance or cost share. And those are two terms for the same thing. And what that is describing is the amount that your insurance company is responsible for versus the amount you're responsible for. So for example, if someone said to you, you have an 80-20 plan, what that means is that once you've hit your deductible, your health insurance policy is responsible for 80% of your health care costs, and you're responsible for the other 20%. And finally, we have the out-of-pocket maximum. So that's going to include your deductible, your copayments, and your cost share. So it's going to include everything that we've talked about except your monthly premiums. Those are not included in your out-of-pocket maximum. And we'll talk a little bit more about how out-of-pocket maximums work in a bit. And then the final term I wanted to talk about was pre-existing conditions. A few years ago, when someone said the word pre-existing condition, it was really only used by the health insurance industry, but it's become much more commonplace and much more talked about. And the reason is that prior to the Affordable Care Act, pre-existing conditions were often used as a reason to deny somebody selling them a policy, right? So once you had a pre-existing condition, it was very hard to go into the open market and buy an individual policy. And oftentimes people felt like they were stuck with whatever they were able to get at work or potentially through some sort of high-risk pool, and it was very challenging for an individual to get health insurance once they'd been diagnosed. Now, people often ask me when I say positive things about the changes we're seeing in health insurance, did we really need these things? And my answer is unequivocally yes, we needed change. And one of the reasons we know that we needed change was the fact that when we looked at all of the bankruptcies in the United States, 62% of them were due to medical debt. Is that better?
Yeah.
Okay, thank you, sir. 62% of all medical debt was due, 62% of all bankruptcies was due to medical debt. And what's even more concerning about that is of those 62%, 78% of those individuals had health insurance. So what that tells us is in the past, just having health insurance was not enough to keep people financially safe once they've been diagnosed with something serious like cancer. Which sets everything up for what I'm going to spend the bulk of today talking about, which is the Patient Protection and Affordable Care Act, otherwise known as Obamacare, healthcare reform. Today we will be referring to it as the ACA or Affordable Care Act. So this bill was signed into law on March 23rd, 2010. So the law is over 4 years old now, but really it's still a baby. And we're still seeing lots of challenges with implementation and changes because the reality of it is it's a behemoth of a law. The law itself is over 1,000 pages. I see some familiar faces. If any of you have seen my earlier talks, we used to actually carry around the hard copy of the law. We now need chiropractic services, so we no longer do that. It's a tremendous law. And like most laws of this magnitude, it is not perfect. It is not the magic pill that is going to solve all of our problems, but it does some really fantastic things when we look at it through the lens of individuals coping with cancer or other serious illnesses. So when I talk about the Affordable Care Act, I'm going to talk about sort of it in two different buckets. So the first bucket is going to be some new benefits and protections that the ACA gave us. And the second bucket is going to be new health insurance options. So starting off with some benefits, one of the first things that the ACA did was deal with something called rescissions. So health insurance companies were in the policy of, or practice of waiting until somebody got sick and then looking back to their original application and looking for any mistake or omission that they may have made and using that as a rationale to cancel their policy. Well, in the past, once you've been diagnosed, you had a pre-existing condition and you couldn't then go get insurance. It was a significant problem in many states across the country. So the ACA addressed this by saying insurance companies can no longer cancel somebody's policy unless they can show that that person committed fraud or lied about something really, really important. The second thing that the ACA dealt with were limits. So many insurance policies had either annual or lifetime limits on the amount that they would pay out for somebody's benefits. And again, this was very, very common, and we saw instances of lifetime limits being as little as $1 million, and we saw some annual limits as little as $50,000 to $75,000, which is about 37 seconds in the hospital. Right? I mean, once you hit that limit, the insurance company wasn't paying anything out for the rest of the year, but you had to keep paying your premiums because once you dropped your insurance, you could never get it back. So the ACA addressed this and said, as of January 1st of this year, insurance companies can no longer impose lifetime or annual limits on things called essential health benefits. Essential health benefits are 10 categories of things that are defined in the law. So we're talking about things like ambulatory care, prescription drugs, mental health, many of the things that we would all think that our insurance should be covering. The specifics of essential health benefits are going to differ state by state, but again, it's those 10 big categories that you can look to. So that's pretty significant. The idea behind these changes is that if you do everything you're supposed to do in terms of having health insurance and paying your premiums, your insurance will be there for you when you need it. What a novel concept, right? The ACA also dealt with preventative services. So we would hear stories all the time of people saying, well, I really need to get fill in the blank, my mammogram, my colonoscopy, my whatever. But I can't because I have a $5,000 deductible and I can't afford to pay that out of pocket. So I'm just going to cross my fingers and wait till next year and see if maybe I'm closer to my deductible then. Well, I think everyone in this room can agree that's probably not the best way to go. So thankfully, the ACA addressed that and said most health insurance policies now have to cover certain preventative services for free. And what free means is that it's covered at 100% without meeting your deductible, and there is no copay. So free is really supposed to be free. Now, we've given some examples here, but if you'd like to see the entire list of preventative services that are included, I recommend going to healthcare.gov, and if you type in preventative services in the search box, the whole list will pop up. The one caveat I will give here is if you have a grandfathered plan, this provision does not apply to you. A grandfathered plan is going to be a plan that was in existence on or before March 23rd, 2010. Does that date sound familiar? Yeah, so if it was in existence prior to the bill becoming a law, then it can be considered grandfathered if it hasn't made substantial changes. For all practical purposes, the only grandfathered plans we still see are large employer-sponsored plans. If you are unsure if you have a grandfathered plan, I definitely recommend asking. So either call the number on the back of your insurance card, talk to your HR representative or whoever deals with benefits at your job. I even recommend doing both of those things and hoping that the answers from both entities are the same, because we often hear some conflicting stories, so you'd want to get to the bottom of that if that were the case. And then finally, we saw a lot of instances where young adults who were maybe graduating college or whose first jobs didn't offer them benefits were going without health insurance. And since we are seeing a trend of more and more young adults being diagnosed with cancer, it was a significant concern. So the ACA addressed this by saying that young adults can now stay on their parents' plan until they're 26. These young adults can live on their own, file their own taxes, be married, have their own kids, and still stay on their parents' plan. But it only applies to the child, so not the child's spouse or the child's children, but just the child. And just because of this provision alone, we've seen over 3 million young adults now have coverage that didn't have coverage before. So that's pretty substantial. So all of this leads me to my number one most favorite slide in the entire presentation. The ACA addressed how much insurance companies get to charge you. And they said that as of January 1st this year, insurance companies can only look at 4 things to determine your monthly premium. Are you buying an individual policy or a family policy? Obviously, family policies will be more expensive. They can look at your rating area or your geographic location. So generally, it is more expensive in large cities than smaller cities to buy insurance. They can look at your age, but even though generally the older you get, the more they can charge you, there are still limits on how much more they can charge you. And then finally, if you've used tobacco. So if you've used tobacco, then they can charge you more. But I will just add the caveat that some states have even eliminated this as an option. So California, for example, they don't take into account tobacco. So those are the only 4 things they can look at. What don't you see here? Pre-existing conditions. They can't charge you more because you have a pre-existing condition. What else? Gender. So most people are surprised to learn that prior to this provision going into effect, insurance companies charged women a substantially higher amount than they charged men for the exact same policy. So that's pretty significant, right, that they can only look at these 4 things. Which leads me to my absolute most favorite provision in the entire 1,000+ pages of the law. And it says that as of January 1st of this year, insurance companies can no longer deny selling you a policy based on a pre-existing condition. So I know it's the afternoon. You guys are a little overwhelmed and saturated. I'm going to say that one more time. Insurance companies can no longer deny selling you a policy because you've had a cancer diagnosis. That is incredibly substantial and changes the way that our healthcare system operates in this country. So,
isn't that only if it's coming through the ACO?
No, absolutely not.
So all of these things that you have previously discussed, premiums, deductible, no cancellations, no lifetime annual limits, free, that's for any insurance?
So the question is, all of the things that I've just discussed, so all of these protections, that's for any insurance? Yes, with some very limited exceptions. So for example, the exception of preventative services, grandfathered plans don't apply to that. There are some other exceptions if you have a retiree-only plan. There are some exceptions, but generally speaking, yes, we are not talking about only if you buy in the Affordable Care Act marketplaces. These are protections that all of us now have. So I have been requested that if you have a question to go to the microphone in the middle of the room. That's okay, I didn't say it before and that was my fault. And I'm also I'm giving you forewarning that I'm going to limit the question so we can get through all of it and get to the end, but I'll take one more.
I forgot what it was now. But getting a Medicare supplement policy.
So Medicare supplement is very different than individual policies,
okay.
And I will give an option to learn more about Medicare at the end of the presentation.
So these things don't necessarily apply for that.
Not to Medicare supplementals. Told you there were some caveats. Okay. Speaking of Medicare benefits, to briefly talk about Medicare, there are some protections for Medicare recipients as well. So it used to be on Medicare that usually you only ended up seeing the doctor if something was wrong. Again, they thought that probably wasn't the best way to roll. So now Medicare recipients are entitled to 1 free wellness visit every year and many of the same preventative care services that I talked about earlier. And perhaps most significantly, there are several provisions to reduce the Medicare Part D donut hole, which will eventually make prescription drugs significantly more affordable to seniors who are on Medicare. Okay, so for all of these things that I've talked about, these kind of fantastic things where they can't cancel policies and they can't charge you more and they can't deny you, there is one thing that we collectively have to do in return for all of those benefits. And that one thing is we have to have health insurance. This provision is known as the individual mandate. You may have heard that term. Now, there's been a lot of discussion in the news about this. I think there's a lot of concern about this provision. But in an attempt to alleviate some of your concerns, I will tell you that for a vast majority of Americans, nothing will change. And the reason is because all of these things count as having health insurance. So if you have an individual policy, if you have a policy through your job, if you have Medicare or Medicaid, if you are on COBRA or have a high-risk pool or in a high-risk pool, you're deemed to have coverage and nothing changes for you. If you do not have one of those things and you choose not to get one of those ways to be covered, you have to pay a penalty. This first year that this goes into effect, which is 2014, the penalty is $95 per adult or 1% of your household income, whichever is greater. And yes, and that is something that is left out of a lot of news stories, right? So people see the $95 and might think, well, $95 is way better than having to pay for insurance. Well, it could be substantially more than $95. So as you can see, the penalty goes up. So in 2015, it's $325 or 2% of your income. 2016, it's $695 or 2.5% of your income, and it will continue to go up from there. The rationale for this is we want people to be incentivized to purchase health insurance because we know through numerous studies that health status improves if people have health insurance. So it is in fact beneficial for individuals to have health insurance. And the ACA has given people new ways to get health insurance. Now, I said that a vast majority of Americans will not be affected by this. There are some exceptions to this rule. So first, you can have up to 1 3-month gap in coverage per year without being penalized. And the rationale for this is that many employers have a waiting period from when you start working to when your benefits kick in. And that waiting period used to be, the employer used to get to decide. The ACA has limited it to a maximum of 90 days. So it can be shorter than 90 days, but a maximum of 90 days. And if you're in that situation and you don't have health insurance, the ACA doesn't penalize you for that. But please keep in mind that even if you are under the 3-month gap, just because you won't be penalized, you don't have health insurance. So if you need a scan or you go outside and break your ankle or get hit by a car and you need medical care, you are paying for that 100% out of pocket. There are also some other exceptions for financial hardship. So if the cheapest plan that you could purchase is more than 8% of your household income, it will be deemed to be a financial hardship and you won't be penalized. If you're a member of an Indian tribe or you're incarcerated or you're undocumented, you don't have to pay the penalty. But again, in all of these exceptions, just because you don't have to pay the penalty doesn't mean that you have health insurance. So this was how the law was originally written. And just to give you an example of how things are changing on an incredibly rapid basis, and why I would say, even for those of you who I see taking notes and taking pictures, please keep in mind that this information may change next week or the week after because things are rapidly changing. When the law was written, this was the definition of financial hardship. So if the cheapest plan available to you was more than 8% of your household income. Well, as the law began to be implemented and real life started happening, we saw the definition expand. And I know it's a little bit hard to read because I don't want you to necessarily memorize all of these, but you can see that it's expanded to include if you filed bankruptcy in the last 6 months, or if you were homeless, or if you've received a shutoff notice from a utility company, and it keeps going. If you have medical bills you couldn't pay. And the last one is if you've experienced another hardship obtaining health insurance. So this goes to show you that the rationale and the impetus behind this penalty, even though we call it a penalty, is not to penalize individuals who are going through rough times, but it's really about incentivizing individuals to purchase health insurance so that they can, in fact, be healthier. Okay, so that's sort of a quick overview of the first bucket. And again, the handout that I passed out has a lot of this information on it as well. Now I want to switch gears a little bit to new health insurance options for individuals. So the first health insurance option I want to talk about is Medicaid. So Medicaid is a federal program that is implemented by states. So the details for each state's Medicaid program is going to be a little bit different. And prior to the Affordable Care Act, in order to be eligible for Medicaid, you had to have a low income and asset level, and you had to fall into another category. So you had to be a pregnant woman or a minor child. In the cancer community, a lot of people fell into the program that is called the Age Blind Disabled program. It's the worst name for a program ever, in my opinion. But unless you had both low income and asset levels and had a disability, you weren't eligible for Medicaid. So that left a lot of individuals that just had low incomes without access to health insurance because they didn't have a high enough income to just buy it. So the ACA tried to address this by creating a new category of eligible individuals, cleverly called the newly eligible. And those are going to be individuals who have income levels at or below 138% of the federal poverty level. And this chart shows you, based on household size, what 138 of the federal poverty level is. So we're talking about individuals who make less than $16,000 a year. Now, this was supposed to happen nationwide in all 50 states. The Supreme Court got their hands on the Affordable Care Act, and in 2012 came out with their decision and basically made this voluntary for states. So states got to choose whether or not they were going to expand their program. And this is where we've come out. This is one of the two slides that changes the most often, and in fact it may even be different from what's on the handout that you guys have. So this shows you that 27 states have expanded Medicaid, 22 are not expanding or have not expanded, and 2 are pending waivers for 2015. But you can see there's a ton of asterisks and exceptions and things happening. So it's created some confusion and some inequities across the country about who has access to Medicaid and who does not. To stand on a soapbox for just a moment, if this is an issue that you care about and you think your state should be expanding Medicaid and you live in one of those 22 states that hasn't expanded Medicaid, I will just gently remind you that we have a very big election coming up in a couple of weeks. And that really is an important thing to talk to your elected officials about if you feel strongly about it, that it's an issue, because it's the only way that things are going to change. Okay, so that's the first new option. In some states, individuals will be eligible for Medicaid just based on their income level. The second option I want to talk about isn't actually an option at all, but rather it's a new way to shop for and purchase health insurance. So when the law was originally written, these were called exchanges. Turns out no one understood what an exchange was, not surprisingly. So they've been renamed marketplaces. There's been a lot of confusion about what these marketplaces are. When you are shopping in these state marketplaces, you are still shopping for private health insurance. So it is going to be companies like Blue Cross Blue Shield, Humana, Aetna. Those are the companies that are selling their product in the marketplaces. So to give you an example, if you go into a mall and you buy a sweater from the Gap, you would say to somebody, I bought a sweater from the Gap, right? I have a Gap sweater. You wouldn't say I have a mall sweater. Similarly, when you buy a plan in these health insurance shopping malls, you are buying a Gap plan, right? A Blue Cross plan, a Humana plan, not a marketplace plan or an Obamacare plan. So there's a lot of confusion about, is this a government insurance policy that I'm buying? And it is absolutely not. If you have a question, can you go to the microphone? I was told. These are not my rules.
I apologize for interrupting, but
That's okay.
Isn't it important, though, to actually have that distinction? Because literally every doctor that I have does not take a mall plan. So if we don't distinguish between the two, are we setting ourselves up for problems in the future to say that they're not distinguished?
So I would say that there's not a problem with saying I bought a plan through the marketplace, but that's very different than saying I have an Obamacare plan, because you don't have an Obamacare plan. You're buying a plan from Blue Cross. And doctors, just like they've always had the option, have the option whether or not to accept particular policies. And even within a company like, I'm picking on Blue Cross, like Humana, a doctor might accept Humana Plan A, but not Humana Plan B. So that part of health insurance has not changed at all. But there are some significant advantages to buying in the marketplace in most states. So in order to buy in the marketplace, you have to be a U.S. citizen or lawfully present. So there's a lot of information in the news or misinformation in the news that this is the administration's way of giving undocumented individuals health insurance. It's just not true because you have to be a U.S. citizen and prove that, or lawfully present. So green card holder, naturalized, etc. When the marketplaces opened this year, they were open to individuals and small businesses. And in addition to some very specific protections about these marketplaces, there's some financial assistance options available in the marketplaces. So there are two types of financial assistance. The first is a premium tax credit. So that's going to be an amount that you get that reduces your monthly premium. The second type of financial assistance is a subsidy, a cost-sharing subsidy. And that's going to reduce things like your copay or your deductible. Did you have a question?
Yes, I did.
Mm-hmm.
Can your employer stop you from getting any insurance besides the one that they offer? Especially if you're working, let's say you're a nurse working at a hospital.
Can I ask you to wait about 10 slides and I will address that? Great. Okay, so these are your two financial assistance options. And eligibility is going to be based on your household size and your income level. So this is how it all sort of shakes out. So if you have an income at or below 138 of the federal poverty level, and you live in a state that's expanded, you'll be eligible for Medicaid. You see that's on the bottom. If you have an income between 138 and 250%, and you buy what's called a silver plan, which we'll talk about in a minute, you'll be eligible for a cost-sharing subsidy. And if you have an income between 138 and 400% in most states, you'll be eligible for a premium tax credit. So as you can see, there are some people that will be eligible for both a subsidy and a tax credit. And when you start looking at the amounts, many people would consider this to be middle class. And I hesitate to use that term because I think there's a wide definition. But when you're talking about a family of four bringing in $95,000, you know that we're seeing a lot of people get financial assistance by purchasing in the marketplace. Now, although a lot of the things I talked about earlier, like rescissions and limits, apply to most plans, these financial assistance options are only available if you purchase in the marketplace. So that is one incentive to purchase through the marketplace. Another incentive is the fact that in order to sell policies in the marketplace, insurance companies have to prove that they are meeting a minimum level of coverage. So remember those 10 essential health categories I talked about? Every plan in the marketplace has to cover those. So there's some quality control involved in what's being sold in the marketplace that doesn't necessarily exist outside of the marketplace. Now, additionally, so there's financial assistance, there's some quality control, there's some standardization involved in the marketplace. And by standardization, I mean a couple of different things. So first, everything has to be presented to you in a standardized format. And this is across the board for all insurance companies. So if some of you have come up on open enrollment, you may have noticed a blue form with very clear lines across so you can actually compare the two things. So you could print out Plan A and print out Plan B and actually look at them side by side and compare them. Again, what a novel concept. In addition to presenting the information in a standardized way, the plans have to have a standardized cost share. Remember, cost share is the difference between what your plan pays and what you pay for your health insurance. So there's four main categories sold in the marketplaces. The lowest level of coverage is called the bronze plan. And those are going to be plans where the plan covers 60% of your health care costs, and you cover 40%. And it goes up by 10, silver, gold is 80-20, Platinum is the highest at 90/10. Generally, bronze plans are going to be the cheapest monthly premium, but they're going to have the highest deductible. Platinum plans are going to be the most expensive monthly for your premium, but many platinum plans have a $0 deductible, so they start covering 90% right away. So what's great about this system is you could say to yourself, well, I'm a survivor. I'm a few years out, but I'm still seeing the doctor on a pretty regular basis, so I think I need a gold or a platinum plan. Right? For me, it makes most sense to pay more up front, but to know that things are going to be covered at 90% right away. So you can say, show me all the platinum plans available to me in my area. And just like you would if you were, say, shopping on Amazon, you can click platinum plans and everything else goes away and you're just looking at the platinum plans. Or you can click gold and platinum and compare those two plans for you. So again, the idea was, let's make it so that people can shop for health insurance the same way we shop for everything else, TVs and cars and books and etc. Also, with these plans, for the most part, there is going to be a out-of-pocket maximum. And the out-of-pocket maximum is going to be $6,350 for an individual and $12,700 for a family. Now, I fully recognize $6,000 is a lot of money. Absolutely. I would love for someone to hand me $6,000 right now. But let me put it in perspective for you. Let's say you got into a car accident and your bills equal $100,000. If you have a bronze plan, great. They'll cover $60,000, but then you'd be responsible for $40,000 if you didn't have that out-of-pocket maximum. So really the idea is these out-of-pocket maximums are to help people avoid the situation where they're ending up filing bankruptcy because they have high medical bills. Okay, so other than cost share and the amount monthly, what are going to be the differences between these plans? So the networks of doctors and hospitals. So in addition to just finding a plan that you think is affordable and covers what you need it to cover, if you have a particular doctor or hospital that you want to continue going to, you need to make sure that the plan covers that, right? And that that's in network, just like you would if you were buying insurance anywhere else. You're going to see differences in copays. So some plans, and we're going to go through an example in a moment, so some plans are going to have higher copays than others. And then finally, prescription drug benefits are going to differ between the plans. And some plans may even have a separate drug deductible than the medical, which is not necessarily a horrible thing, right? If you only have a $200 medical deductible and a $200 drug deductible, not that bad. But it's still an important thing for you to know as a consumer going into it before you purchase the plan. All right, so states had an option. And again, 2014 was the first year of these marketplaces. And we saw some states create their own marketplace. Some states partnered with the federal government to run the marketplace. And some states defaulted to the federal government completely. And this is where this all shakes out. This is going to change for 2015. And will probably change for 2016. So it is flexible. The reason we talk about it is because we think it's important for you to know what's happening in your state. There's a couple of differences that will matter depending on whether you have a state-run or a federal-run program. The first is where you actually go to look for information. So the state-run marketplaces have their own websites. The federal and the partner marketplaces go through healthcare.gov. But everybody can start at healthcare.gov and you put in your state and it will point you to the right direction. Okay. Oh, look, and there's more information. So I actually had to include this slide because I would always forget to talk about the fact that even though I happen to talk a lot about these marketplaces as being online, they are not just online. There is a phone number. You can get a paper application and mail or fax it in. And perhaps most importantly for a lot of folks, there's in each state something called in-person assisters. So there are actually human beings trained, hopefully, in the marketplace and helping people enroll. And so if you are confused, don't feel comfortable on the internet, for whatever reason, would like to speak to someone in person, you can go to healthcare.gov and type in your zip code, and it will show you all of the different assisters near you. So forgive me that I talk a lot about it being internet-based. There are multiple ways to access the marketplaces. So the open enrollment period for 2014 is closed. The next open enrollment period is coming up. So it starts November 15th and will go all the way through February 15th. No matter when, I shouldn't say it that way. Even if you apply November 16th for a new plan, the earliest date your coverage will start is January 1. But the idea, just like all open enrollment periods, is to give you enough time to shop for, to search through, and to decide what plan makes the most sense for you. If you want your plan to start January 1, you must enroll by December 15th. If you enroll after December 15th, it won't start until the first of the following month, so February 1st. Okay, so just keep that in mind. If you need coverage January 1, your open enrollment period is shorter. If you've had a plan this existing year in 2014, the government has just said that they will automatically re-enroll people in the plans that they were in. And it was done as a way to make sure that people who weren't on top of things didn't lose coverage. So on the one hand, it's a good thing. On the other hand, I would say even if you love your coverage and you want nothing to change, please do take a few moments to go through the marketplace because new plans are frequently being added. Benefits may have changed in your plan. So again, to be a good consumer, to make sure you're getting what you think you're getting. And also to update any financial changes. So if you think you're going to make less in 2015 than you did in 2014, go and update that information because you may be entitled to a bigger tax credit in that instance. So the automatic enrollment is great with the caveat that I think you should all be good consumers and make sure you're getting what you think you're getting. Medicaid applications, however, are accepted year-round. So now what happens if something in your life changes outside of this open enrollment period? Because, things don't just change in the dates that you need it to change in, right? There is something called a special enrollment period. And so for any time where there is a life-changing event that affects your health insurance status. So you've lost your job, or you've reduced your hours from full-time to part-time, so you're no longer eligible for benefits. Or you've gotten married or divorced, or your spouse has passed away, or any of these kinds of things. It's going to trigger a special enrollment period where you have 60 days to then go into the marketplace and shop for insurance. Excuse me. So don't worry that if something changes in your life outside of open enrollment, you would still have the benefit of special enrollment. Okay, so to sum all of this up, if you were to go to healthcare.gov and put in your information, and you can do this today even though open enrollment hasn't started, and you can put in some pretty basic information to start with. So this individual is looking for him and his spouse, who are 35 and 40, and they live in McHenry County, Illinois. So that's all the information they've put in. And the fact that the two of them have a $50,000 income. This is what would pop out. So for these individuals, you can see there are 5 different health insurance companies that they can purchase from. And of those 5 companies, there are 56 different health plans. So there's a lot of stuff in the news that I read that says this limits consumers' choices and it's terrible for that reason. Well, frankly, I find 56 choices a little overwhelming, frankly. But the good news is you can narrow it down because remember, you can make a decision based on your needs to narrow down, I don't want to look at the bronze plans. I know those aren't going to be sufficient for me. Or I can't afford a platinum plan, so let's only look at gold plans and narrow down your choices from there. This page also shows that these individuals are eligible for a $60 a month tax credit. So, as you scroll down the page, this is the information you would start to get. So, this is a PPO bronze plan, because that's something else I may have failed to mention. The policies being sold in the marketplaces are both PPO, HMO, and point of service plans, or fee-for-service plans. So again, there's a lot of choice and a lot of flexibility as a consumer that we have now. So on this page, you can see that for a bronze plan, it would cost this couple $268 a month. So it's pretty cheap monthly for 2 people. But check out the deductible. The deductible is $12,700. So they have to pay $12,700 out of pocket before their plan starts picking up 60%. So generally, for most individuals with a cancer history, bronze plans are not going to be the way to go. So I just wanted to compare that with 2 platinum plans. So these are both platinum plans. One is an HMO, one is a PPO. $667 a month for 2 people, so keep that in mind. And their deductible is $2,000, but their out-of-pocket maximum is $3,000. So again, they are paying more upfront monthly to know that all they are going to pay out of pocket, other than their monthly premiums, is $3,000 for covered services. So the question was, does the $3,000 include the $2,000? Yes, out-of-pocket maximums are going to include your deductible, your copay, and your cost share. So everything but your monthly premium is going to be included for covered services. Can you go to the microphone if you have a question?
It's just a quick one, I'm sorry. I'm just making sure I understand.
Sure.
So the prices in bold are what they're going to pay after their tax credit is applied?
So their tax credit is applied here.
So that's the cheapest they're going to get. The $60
Yes.
has been in. Okay.
Yes, for this example. But I definitely recommend go on to healthcare.gov and play around with it and see what it would be for you and your family. Because again, this is just an example I made up. Some of the other information that you'd get from this page are the copays. So I know it's a little hard to read, but a primary doctor is going to be $25. Specialist doctors, $35, which sounds like a lot, but remember, what's your out-of-pocket maximum? It's $3,000. So there are some significant pros and cons to the different levels of coverage. Now, let's say you've decided, well, I really think I want the PPO. I see a lot of specialists, I want the PPO Platinum plan. You could click on the details button here, and you would get something that looks like this. And what's important about this page is where the arrows are links where you can get more information. So you can actually get the summary of plan benefits, which I know doesn't sound like a shocking thing, but if you've ever bought insurance in the individual market prior to the ACA, you may not have been able to access this until you bought the policy. And the same goes for the prescription drugs covered. You sometimes had to buy the policy and just hope that it was going to cover the prescription drugs that you needed. And that's not the case anymore. You can also see a provider directory here. The caveat I will give you is do not 100% rely on the information that is included in this, because guess who inputs this information into the website? Humans. And what do humans do? Make mistakes. So what I would say is you can use it as a guidepost, certainly, but also, again, if you have a particular doctor or hospital that you are adamant about going to, double check. Call up the doctor's office and saying, I'm thinking about buying this PPO. Do you accept it? Doctors' offices are normally more than willing to give you that information. So to sum it all up, almost everything in that right-hand light green column will continue to exist, much of with improvements. So individual plans, employer plans, Medicare, Medicaid, etc. There are some new options and benefits that started in January of 2014. If your state expanded and you have an income at or below 138% of the federal poverty level, you'll be eligible for Medicaid. If you're between 138 and 400% of the federal poverty level, you'll be eligible for financial assistance to buy in the marketplaces. If you have an income over 400% the federal poverty level, you still get to buy in the marketplaces. You get all the benefits of standardization, quality control, etc., to buy in the marketplaces. Now, I was also asked to talk a little bit about appeals. And we go to 345, right? Does someone have an agenda? 345? 355. Oh, good. So to talk a little bit about appeals. So a lot of times we will hear from folks, well, my insurance company denied it. Fill in the blank for it. And the question is, do you have to take no for an answer? And we would adamantly say no. Because there are a lot of reasons that you can try to appeal a decision. And in the cancer context, what we hear perhaps most frequently is appealing a decision for a denial because the drug used was experimental or investigational. And how that happens most generally is when a drug is created as, let's say, a treatment for breast cancer, but then we're starting to see some positive things with thyroid cancer come out of this drug. Well, if it's prescribed for thyroid cancer, insurance companies can deny it based on it being investigational because it was created as a breast cancer drug. So what do you do if you're in this situation? And the answer is you can appeal it. So how do you do that? The first step generally is to do an internal appeal. And this is going to be very specific to your health insurance policy. And so I definitely recommend that you get this information from your policy and you follow the instructions to a T. So if it says it has to be on, white paper, 12-point font, do whatever they tell you to do because they have very specific rules. I put up the little engine that could to remind us all that this is generally an uphill battle and that you have to be persistent. And while this is probably the last thing that you want to be spending your limited time and energy on, it can be really beneficial. I also recommend that this is somewhere where you do your best to be the most organized you have ever been in your entire life. And one of the ways that Triage Cancer has tried to help people do that is we've actually created a appeals tracking sheet. You can get it on our website. It's just a PDF document you can download, and there's spots for you to actually keep track of where you are in the process because it can be really easy with all the paperwork that's being sent to your house and that you're dealing with to lose track of where you are and who you spoke to. Now, if you go through the internal appeals process and the answer is still no, the next step is something called an external appeals process, otherwise known as independent medical review. Now, thanks to the ACA, every state has to have an external appeals process now. So it's going to vary a little bit state by state. But generally, these are the steps that you will go through. So you generally have to be notified that you have the right to file. You apply to file. The state comes back and says, yes, you're eligible. And then the review process happens. For both the internal and the external appeals processes, it is imperative that you engage your healthcare team. Because it's going to be your healthcare team that's going to be able to give you the documentation and the background and the proof for why you got the treatment you needed or why they did it however they did it. 9 times out of 10, your healthcare team is going to be more than happy to help you do this. But if they don't know that you're doing it, they can't really be helpful. So again, and it sometimes is going to take multiple requests. So they're very busy most of the time. They're incredibly overworked. So you might have to ask for something more than once in order to get it. So just remember the little engine that could. Independent medical review or external review is binding. So whatever the answer is at the end of this is going to be the answer. All right, so this is just a flow chart of the process for an appeals. So you get the treatment. You, or usually your doctor, files the claim to the insurance company. And then there's two things that can happen, right? Your insurance company can approve the claim, which is delightful. And we're on the left-hand side now. So the insurance company approves the claim. They send their portion to the doctor. The doctor sends you a bill for the rest of it. You pay your bill. That's best case scenario, right? The more complicated scenario is if the insurance company denies the claim. So we're over here now. So you file the internal appeal, and if you win the internal appeal, then you scoot back over to the left-hand side, the insurance company pays their portion, you pay your portion, you move on. If you lose the appeal, down here, you then get to file an external medical review. If you lose the external medical review, you're responsible for the entire portion over here, and you'll get that bill from your doctor. If you win the external medical review, it goes back up, the insurance company pays their portion, you pay your portion. So I know that's a lot. This flowchart's available on our website, so if you didn't get a picture of it. But I just know that it can get a little bit confusing with all of these terms, how the actual process goes. Okay, so I've thrown a lot of information at you in a short amount of time. But I just wanted to tell you a little bit about Triage Cancer and to give you the reassurance that this is not the last time or the last opportunity for you to get information about this. So we are a national nonprofit organization that's dedicated to providing information and resources on the entire continuum of survivorship issues. And we define survivorship as the moment of diagnosis. So if you have survived for a second, you are a survivor in our book. We do this in a couple of different ways. So we host a speakers bureau. So if you go back to your communities and your hospital or whatnot is putting on an educational event and they're looking for a speaker, they can contact us and we'll match them with an appropriate speaker. We also put on educational events, seminars, webinars, teleconferences. And then we have all of our online resources. So we have handouts like the ones I passed out today. We have a blog, which what we try to do on our blog is keep up to date about all of the changes. So every time something comes up with healthcare reform or some other Medicare open enrollment, we try to do a short blog for folks so that if you only have 5 minutes, you can get the information that you need in that limited amount of time. There's our pretty blog. Two things I did want to talk about specifically about the Affordable Care Act because open enrollment is coming up soon. Triage Cancer has webinars, and I've gotten a couple questions about Medicare. I know I didn't go into a lot of detail about Medicare given the time that I was given. I could talk about this stuff for 8 hours straight. On Monday, we are doing a webinar on Medicare basics. So Medicare open enrollment started 2 days ago. So if you'd like to join us on Monday, we'd love to have you. Just go to our website and register. It's totally free to attend. We also record them, so you can go to our webinar and access them later if you're not free on Monday to listen to it as well. The only disadvantage of listening to it after the fact, obviously, is you can't ask questions. Also, we partner with another organization called Cancer and Careers, and I am presenting one more call specifically on the Affordable Care Act in November. You can find all of this information on our website as well. So some of it will be repetitive to what you've heard today, but what I've been told in the past is it's sometimes helpful to hear this more than once because it is a lot of information, and I recognize that. So we'd love to have you in any of those circumstances. And then our website, triagecancer.org, which should be on the handouts as well, is where you can find a lot of the resources. So in the time left, I'd be happy to take questions. But remember, you have to go to the microphone.
First, thank you a lot. I don't know much about the Affordable Care Act. Probably should have looked more into it. But
do you know more now than you did when you sat down?
I definitely do.
That's the goal.
So now I have a key question because I just always assumed I worked for a corporation. Never really looked into it because I have my benefit through my employer. So obviously the plans that they offer me have to meet a lot of these requirements now. But I had the question earlier. Do you have the option to not take insurance through your employer and look through the marketplace? Is that even are typically corporations, the plans that they do because they're en masse,
right?
They're better options.
Thank you for reminding me, and I apologize. I told you to wait a few slides, and then I just realized the slide wasn't in this deck. we do this presentation multiple times a week, so sometimes I think there's slides that aren't end up being there. So with employer-sponsored plans, you always have the right to opt out of your employer-sponsored plan and buy insurance elsewhere. Always. You still can do that with the marketplace even. The caveat being, if you have an employer-sponsored plan that is deemed to be affordable and adequate, you will not be eligible for financial assistance. So you can shop in the marketplace, but you just don't get access to those tax credits or those subsidies. So affordable means that your portion that you pay for that insurance is more than 9.5% of your income. Inadequate means that it covers less than 60% of your healthcare costs. So what does that remind you of? I heard it, a bronze plan. So it has to at least be a bronze plan to be considered adequate. If it's unaffordable or inadequate, then you have the right to say no thank you and shop in the marketplace and be eligible for financial assistance. So no matter what, you can always say no thank you, I'd like to buy a marketplace plan, but you're only going to get financial assistance if it's unaffordable or inadequate. In terms of your question about is it better or worse, I cannot speak generally to that because it's really going to just depend on the plan. Some employers have great plans, some not so much. It might be about you having a specific network that you need to see and your employer's plan doesn't cover that network, then it might be better for you to shop in the marketplace even without the financial assistance. So that I can't answer for you. That's something you're just going to have to look into.
And one more follow-up question, because obviously we're all cancer survivors, we have prescriptions. So although I have a great plan, my prescription coverage is like gone through the roof. And so I hear a lot about these supplemental programs, and I don't know if they're actually, one, legit, or two, if it's through the Affordable Care Act or how.
So generally supplemental programs are through Medicare.
Okay.
I would be very careful about buying a general out in the world supplemental plan because as with everything, there's a lot of scams out there. But that's not to say that a good one for you wouldn't exist. Okay. So what I would recommend is talking to your healthcare team to see if there are other people in your area with the drugs that you're getting that have purchased a supplemental plan and have had good experiences. That would be my best suggestion in terms of that. Thank you. You're welcome.
Thank you. My name is Andrew. The question I'm asking you is, a lot of insurances do not go into universities hospital.
Okay.
That's the word I said. No, we don't go to University of Colorado, Nebraska, whatever. How do you find out who does and why can't they go in?
So the issue with that is not even really an Affordable Care Act issue. That's an issue about the discussion between the university and the health insurance plan. And that's always going to be the case where particular universities or doctors have the option whether or not they're going to take a particular plan. What I would say is if you go to University of Colorado, go talk to their billing department and say, I'm looking to shop in the marketplace. What plans are being sold in the marketplace that you see good success with? They're the ones that know how it really works on the ground.
It's fine. Thank you very much.
You're welcome.
I guess this is clarification of what I was saying and following up on the question about that. When I was talking about them taking exchange insurance, it wasn't that I had a specific plan and that they said, oh, we don't take that. It was actually the doctors that I've been calling and dealing with. And unfortunately, all of them say that they don't take exchange plans, period. And so they were actually not saying, hey, that plan we don't take. It was actually, they were grouping all these exchange plans together and saying, no, we just don't take them. And the reason for that I've heard from the doctor's offices is because they reimburse more poorly. And so the problem for me, my first round with thyroid cancer was botched, and I had a horrifying experience at one institution that's actually a highly reputable institution, sadly enough. And I had to go to literally one of the top guys in the world to go and take care of my care. And unfortunately, I've seen this pattern in a lot of people. And so my concern, with the exchange plans and the concerns that I've heard expressed by a lot of other people in this position is that they won't have access to top doctors. And unfortunately, so far, just anecdotally, that has played out in the phone calls that I've made and the doctors that I've dealt with. They specifically will not take exchange plans.
So I think that it's a valid concern. I think that the issue is not with the exchange plans. I think the issue is with the doctors, because the doctors get to make the decision whether or not they're going to accept a plan. And the discussion about reimbursement rates is a little bit of a falsehood, because the reimbursement rates through the plans that are being sold in the marketplace are not all that different from the plans that Humana was offering outside of the marketplace. So there is a lot of discussion within doctors and with hospitals that is misinformation. What I would recommend to you is try calling a couple of times, because here's the other piece of this puzzle. Not all billing people or HR departments are created equal. So if you say I'm buying a marketplace plan, they might not actually understand what in fact that means. And I've had instances where people are confused that, are we talking about a Medicare plan? Are we talking about a Medicaid plan? What are we actually talking about? Mm-hmm. So generally the best way to ask the question is, I am buying the Humana 3000 PPO. Are you accepting that? Okay. And I can't guarantee, but I would guess in some instances at least the answer may be different.
Okay, thank you.
Sure. Remember what I said earlier. This is not the magic pill that solves all of our problems. There are still problems. There are still things that need to be fixed. I do think over time, though, we will see fewer and fewer plans being sold outside of the marketplace. No. So there are going to be more instances where doctors are going to be forced to have to take certain plans. Are we being cut off? I'm happy to take one or two more.
I have one quick question, actually.
When's the next session?
Mine's really-
Okay, well, I can take two more questions, because I have to speak in another session.
I have just one really quick.
Yeah.
So my healthcare plan, the prescription drug piece of it, they require mandatory generics. So, but I take Thyroid. That's what I found worked best for me. Mm-hmm. Is there a way that I can
appeal it?
Yeah.
Yes.
Okay.
Yeah, that you'd go through the appeals process.
Okay.
Exactly.
Cool.
So,
that's it. Thank you.
Okay, I'll take one more because you were next.
Okay.
Okay, hurry.
My husband just lost his job, so our insurance runs out the end of October. So, but what do we do for November and December?
Special enrollment. You can buy in the marketplace for 2 months.
But I thought it didn't take effect till January.
Only if you're applying through the open enrollment period. But because you're losing your health insurance status, that qualifies you for a special enrollment period. And it would start the first of the following month.
If the same plan is there, because we just finished paying our individual deductibles, would those apply?
No.
Okay.
The only way that would apply is if you elect COBRA.
No, it's $2,000 a month. What a joke. You've lost your job.
So, yeah, so that's the one caveat to that. But you could qualify for a special enrollment period. So thank you so much for hanging out with me and sticking through it all. I appreciate it.